Okay, good afternoon, everybody. Thank you so much for the invitation. And nowadays, we are living the future because we have a promising horizon in front of us due to the new tools that we have available, like artificial intelligence and the big data, that is allowing us to move from the evidence-based medicine era to the personalized medicine, in which we are selecting a specific treatment for specific patients. And of course, in these specific patients, we have to consider as well outcomes that really matter to the patients. Because it's important for us to know what are the expectations of the patient with our treatments and with the stone disease, and it's important to inform the patients about the impact of our treatment or the stone disease is going to produce on our patients. So the key question is, how can we do better with stone disease? And I think that the answer for this question is to identify in our patients the chronic disease condition. It's an important aspect to try to increase the quality of life of chronic patients with a stone disease. Because in the majority of departments, we treat the stone disease, we diagnose the patient, we treat the patient, and we discharge the patient. And we are waiting for the patient because we know that the patient are coming back in 5 or 10 years with a probability of 50%. So I think that we have to change the way of treating our patients, and we should to treat a proactive management of our patients, and we should classify our patients depending on the risk of recurrence. So we have used a Kaiser Permanente pyramid stratification in our population with stone disease. And for more than 400 patients that we treated in 2012, we score every risk factor in our patients, general factors, environmental factors, lithogenic factors, and we use a specific classification that we use in this region to evaluate the comorbidity of the patient. So each patient obtained each score, and with a complex mathematic model, we built our own Kaiser Permanente pyramid. And we know now that the 60% of the patients have a very low risk of recurrence, so these patients are candidates for a self-care support. We know that the 36.5% of our population with stone disease has a high risk of recurrence, and they are candidates for a disease management, and we know that the 4.5% of the patients have a very high risk of recurrence. So, more or less, in this population, in Valencian population, we know that a person who has a stone disease has a probability of 41% of have a high risk of recurrence stones. And the patients with a high or very high risk are candidates to case management, adapting the follow-up and the treatment depending on the risk of recurrence. But the question is, how do we apply this? We try to make an interference in the natural history of the stone disease, and for that, we can control the urine pH, and we should reduce the possibility, the aggregation, the crystal aggregation. Why modify pH, urine pH? Because we know that some crystals are going to increase the aggregation depending on the range of the urine pH. So you know that the uric acid stone and thus increase the aggregation for urine pH below 5.5, or we know that the infection stones can increase the aggregation of crystals above with a pH, urine pH above 6.2. So which is the best method to control urine pH? We know that the lab stick is probably the most used method to evaluate that, but I think that is not accuracy method for that because it lacks the precision that we need to control the urine pH in our patients. So we have nowadays different automatic methods. It's reliable from DeviCare. It's an automatic electronic pH meter that is reliable, is accurate, and is easy to handle. And we know that it's a reliable pH measuring device for control urine pH in our patients. The second point is how reduce aggregation of our patients. We know that for calcium oxalate stones, we can combine the use of phytate and magnesium because we are going to inhibit calcium salt crystallization and complex of oxalate. But this combination is not going to modify the urine pH. For uric acid stones, we can combine potassium magnesium citrate and theobromine because we know that we are going to inhibit uric acid crystallization and we are going to modify the urine pH. We are going to increase the urine pH and we are going to avoid the aggregation of the crystals. Because we know that theobromine is a specific inhibitor of uric acid crystallization. So if we have in front of us a patient with infection-related stones, in these cases, perhaps the best combination is L-methionine and phytate, and the combination of that are going to inhibit estrubite crystallization and decrease urine pH, avoiding the aggregation of this type of crystals. So this is a simple scheme or schedule of we usually use this type of drugs because for calcium stones we use only a lead control pH balance because it's important to keep the patient in the protective range of pH. For uric acid stones, we have to increase the urine pH, and for infected stones, we have to decrease the pH, the urine pH. And so for this schedule of classification, many years ago, we developed a clinical trial in which we compare a control group with a standard follow-up, and we compare with an interventional group with adapted follow-up depending on the classification of our Kaiser Permanente pyramid. And we can see that for 2 years of follow-up, we have reduced in more than 40% the recurrence of the patients with a high risk or very high risk. So I think, for concluding, that the most important is identify the patients with a chronic condition of stone disease, classify the risk of recurrence of our patient, and of course, we should interference the natural history in these patients, modifying the urine pH if it's necessary, and trying to reduce the crystal aggregation. Thank you so much for your attention.